During that year, during the 30s, Putnam from Boston, developed an animal model based on occlusion of cerebral veins and on dogs, and he found abnormalities quite similar to encephalitis or to multiple sclerosis. And his conclusion was that the venular obstruction is the essential immediate antecedent for the formation of typical sclerotic plaque. And this has been published. It was published in 1937. The topography of veins and plaque in the spinal cord was subsequently described also by Aaron and Alexander very well. And this picture illustrates how the emergence of a multiple sclerosis plaque is related to the vascular system and more specifically to the venular system of the brain. I was reached by a communication of Franz Selling in 2002, and he emailed me because at that time, as a surgeon, I was interested in valvular reconstruction, also at the saphenofemoral junction, to try to find something conservative in disorders of the lower limb. And he very kindly also provided me with this beautiful topography of plaque in multiple sclerosis with special reference to cerebral plaque written by Thurman and Fogg and published in Denmark in 1965. This is a fantastic, really fantastic work of a neurologist who followed up his own patient along years, and at the death performed, this is an example, performed the autoptic study, but in a particular way, trying to have a preservation, careful preservation of the venous system, and finally concluded that probably the progression of the disease is countercurrent respect the normal flow observed in or expected in the brain venous system. In the 70s, there was the introduction of catheter venography or catheter angiography in the world, and a lot of the radiologists tried to explore the vessels that were never investigated. And it was amazing that in French, published on Acta Radiologica, a group with Abul Kher and other, Leorich and other radiologists find 98% of spastic paraplegias presenting 2 or 3 stenoses at catheter venography. Venography were found in the jugular vein, in the valgus vein, hemiadygos, renal vein, and they described this kind of association. We do not know nothing about the patients, and also they tried to operate this patient but with poor results due to heavy complication, and so this story quit. In the 80s, there was fantastic observation in London due to Adams, who was a professor of histopathology in St. Thomas Hospital in London, and he found microbleeding and perivenous iron stores in 47% of his material, especially in patients who died for other causes with relative early onset of the disease, and also, very interesting, a marker of venous hypertension in about 25% of people, because he found the venulars encircled by fibrin calf. And he described this and considered this as a neglected part of multiple sclerosis pathology, because it's more addressed to the relationship between the venous wall and the plaque and the inflammation seen in the multiple sclerosis. In the 80s, there is also good work on behalf of Franz Schelling, who was yesterday awarded by the International Society for Neurovascular Disease. He also found skull radiography in MS demonstrating striking widenings of the main venous passageways, and he extensively investigated this, considering also reflux as an overlooked part of the disease, venous reflux, and also proposed venous hypertension as a possible trigger of the disease. In the 90s, at the beginning of the 90s, or between 90s and 2000, there was a fantastic improvement in MR venography, and so it was easy to demonstrate the venocentricity of the plaque. This is probably the first study demonstrating that there is in 98% of the MS plaque a vein in the central part of the plaque exactly splitting the MS lesion. So this is very interesting because all the inflammation and the infiltration of the inflammatory cells is just around the central vein. In 2002, I tried to move out of the skull. Probably it was the first research looking at multiple sclerosis, trying to investigate the circulation, the venous circulation out of the skull. And this is the first case of reflux that I found at the junction level of the jugular vein with no Valsalva and simple activation of the thoracic pump, inviting the patient to breathe. I did not have a right probe to explore the supraclavicular fossa. You may see in the B-mode image that there is a shadow due to the clavicle. And at that time, I was convinced that this reflux probably was due to an external compression by bone or something like this. And I asked to my patients, to my normal vascular patient, if they were capable to propose to someone, relative or friend suffering from MS, to have a duplex investigation. And I found about 50 initial patients, and in about 55% of these patients, initial patients, I found really venous flow abnormalities by investigating these patients. But at that time was completely not capable to create a protocol by investigating findings related, for example, to physiology or something like this, that were coherent with this kind of abnormalities that I found. Also, I explored in postmortem studies, and I found these are veins which you may easily see intraluminal defect like septum membrane in the jugular vein. So I began to understand that probably there was something different by simple external compression, because I found evidence of intraluminal defect. And look at this. This is very interesting. No, sorry. This is a big, this point you may see a big inferior thyroid vein, never seen in a patient with MS. This is a collateral circle, very enlarged. This is one of the more characteristic substitute circle, because from the jugular vein, blood may shunt into the superior thyroid vein, run along the thyroid gland, and re-enter into the chest through the inferior thyroid vein. So I was very, very impressed by these post-mortem studies, by my very pioneeristic duplex observation. And so, in a lectureship at the Royal Society of Medicine in 2006, I tried to propose a parallel in a very provocative way between MS and chronic venous disease of the legs. And this was mainly based on histology. You may see that there is extravasation of red blood cells here. This is MS, and this is in the chronic venous disorder of the leg. We found also fibrin calf that was considered from 1982 a marker of venous hypertension. It was published by Bruce and Burnham as a marker of venous hypertension in the vein of the leg. And also you may see very, very easily that both diseases present macrophages migrated through the blood-brain barrier or through the venular side of the microcirculation, and these macrophages taken up iron. So this, I consider these similarities and very, very, very interesting. And shortly after this, I had a fantastic email by Dr. Aki, and he showed immediately his fantastic SWI imaging of iron in MS, and from that moment we began to exchange by email. I sent him my histology of iron in MS around the plaques, and he replied me by beautiful MRI imaging. So we started for the development of an ACD quality protocol by using a combination of physiological measurement and trying to compare patients and controls. And this convinced my ethical committee that there are really abnormalities in the extracranial venous system in patients with MS, and giving me the permission to investigate the patient with invasive catheter venography and the possibility to use just simple venous angioplasty in case of evidence of stenosis. So we chose a conservative, very simple treatment because at the time there was no evidence at all of the role of this stenosis. This is one of the first cases that really give us all the elements of CCSVI, the stenosis, the hypoplasia, the collateral circulation, respect to normal control. This is the first Dygos case. It was operated on December 11, 2006 by Roberto Galeotti, who is the head of our interventional radiology department in Ferrara. And 2 days later, he operated the first case on the jugular vein. This is depicted. This really was the beginning of the history. In 2007, we had our ethical committee approval. We published the first seminal papers on CCSVI, and this was a very important part that I recommend to everybody. The constitution of an interdisciplinary team is mandatory to have good results. So we found a neurologist, we have our interventional radiologist, our vascular surgeon, vascular technician. All these figures are really very, very important if you should consider to establish a program on CCSVI. This is our team at work, and I was always very interested in understanding how many calories are necessary for the life of a neurologist, because it was my first contact with this kind of colleague. But really, Dr. Salvi, you may see, is always in our picture. I didn't find a picture without food. Big lobster. This was Doppler examination, blinded, but with cakes and pizza and everything, every day and night of what we collaborated. So it was very fun. This is the first case operated on during a relapse for right hemiparesis. This is the Magazzini proof that show the hemiparesis of this young patient. And 2 days after the PTA, the patient was completely stable without any steroid treatment. And this suggests us that certainly for the rapidity of, in an acute case, this is a very important concept. This is not a chronic case. This is a relapse. But also the rapidity of the recovery after the relapse following PTA convinced us that there was certainly a causal relationship between venous disorders and the complex puzzle of VMS. In 2008, I was kindly invited at a ground round lecture at the University of Buffalo with my friend Robert Zibadino. We had big discussion, you may imagine, if you should know him. Big discussion. And we have another one meeting during summer in Croatia. Was very easily to be reached by me. And in July, I reached him in Abbazia. It's a beautiful place, really, in Croatia. And we tried to project a common work that was CVI-MS and FT-MS studies, and was really a big effort, a fantastic experience together, because it was a transatlantic cooperation with patients coming both from Buffalo to Ferrara for procedure, and our patients that were checked by Robert in a very sophisticated way by MRI with new, non-conventional also MRI measurements. So we really learned a lot of pathophysiology of CCSVI thanks to this cooperation. This was the group of the Niagara Falls, and again was invited by Dr. Salvi in a beautiful restaurant, of course, in Bologna. So this was again food. In 2009, I presented the first cases in a very important congress for the vascular people, was Charing Cross in London, chaired by Professor Greenhalgh, and I met Dr. Dake, and really was fantastic, because few months later he performed the first procedure also in Stanford in the United States. So this was really fantastic. And few months later we had the first meeting of people interested, interdisciplinary people in Bologna again. It was the first CCSVI meeting. And now this is a reality. The reality is all people that are figured and are interested in this topic. This is the first INSNVD Congress last year, and we have a second annual meeting today. But to me, the more fantastic thing is the poster outside. Poster outside is fantastic because 2 years later we have a lot of young investigators that are performing research in this field, very interesting findings, and this is fantastic because this is the life of science, to have young investigators, young researchers that are working on this interesting theory and hypothesis. I think that this is not the end, but it's the beginning, because This is a recent Google Scholar, and I found more than 6,000 citations on CCSVI. Thank you very much for your attention.
Thank you, Paolo. This is a lovely history, and I've enjoyed it.
Thank you.
I think we have run well over time, but we can take one question while we're getting ready for the next presentation.
I wonder if you could briefly relate to the group the story of your experience in Sardinia with the children.
Yes, but at that time I was not capable to understand nothing, really. I was a young surgeon, and I found a lot of jugular malformation in childhood in my vascular laboratory. And they were called by Abbott and important people as primary venous aneurysm. At that time, I did not link it, jugular malformation with MS, but you know Sardinia is one of the more hot places in the world for MS. There is a big prevalence, but I don't link this at all. And I performed some procedure. Some were open angioplasty, and some other were excision of this venous aneurysm. So I found the same histology in the pieces that will be described by Dr. Cohen in Geneva. So this was very interesting. But unfortunately, I was capable to find only 2 children 20 years later. One of these had simple excision and developed MS, and the other had angioplasty and did not develop MS. But this is really anecdotal, and probably not of scientific importance. Thank you.
Thank you. The next presentation, Post-Mortem Assessment of Jugular and Zygous Vein Pathology, is by Dr. Robert Fox. Is Dr. Fox here? Great, thank you.
Well, thank you very much. It's an honor to be invited here to share with you the preliminary results of our pathologic studies. I should point out that the credit for this goes to a couple of my colleagues. Claudio is a medical student who has devoted the last year and a half of his time to this study. Both our ultrasound and MRV cross-sectional study, as well as the pathologic study, and he has helped develop this technique under the guidance of our neuropathologist, Susan Stegaitis, and our anatomist, Jennifer McBride. So they get all the credit for the work that I will be presenting here. These are our disclosures, just to give you a sense of them. They are also will be provided in the online posting as well. So up to this point, the majority of the evaluations for CCSVI have involved ultrasound, MRV, and catheter-based venography. There have been some single cases, like Professor Zamboni just showed, of looking at the tissue itself, but in general, evaluation of the tissue itself has really been thin up to this point. And so we sought to evaluate at a pathologic level the CCSVI hypothesis, looking at both MS patients and non-MS controls. I'll warn you, for those who are a bit squeamish, particularly here after lunch, I'll be showing you some potentially squeamish images. So if you have a shy stomach, you can look down, and I'll tell you when to look up in a moment. But first, our methods was to develop a procedure to obtain veins related to the CCSVI hypothesis or theory post-mortem, to describe the various venous abnormalities possibly related to CCSVI, and then to assess the prevalence of these venous abnormalities in MS and non-MS controls. What I will be showing you here is interim results from our studies, which are about half to two-thirds of the way through. We had two sources of cadavers, of tissue donors. One was our MS brain donation program, which has been standing for a little over 10 years at the Cleveland Clinic. We bring in about 10 to 15 brain donors per year. We modified the consent to include harvesting the neck and chest veins. We also have a general body donation program at the Cleveland Clinic where people donate their bodies for medical research, and that is where our non-MS controls came from. The current interim results I will be showing you is from 7 MS donors and 6 non-MS controls. I'll be showing you some anatomic variations from a slightly larger group. So this is the gory part. Again, if you're shy, you can look away. We had to develop the technique for capturing these veins, for harvesting them. This was not well established in the literature previously, so we had to develop this. It started with an incision from one shoulder down across the chest to the other shoulder, reflecting the pannus of tissue up over the head, and then accessing the internal jugular vein, the subclavian vein, and the azygos vein, as shown here. We then flushed the veins with water and then followed that with a fluid silicone injection. Because it was veins, of course, we had to color that blue, although it can be colored any color one wants. Allowed to cure for about an hour, and then dissecting out the specimen in one piece with a silicone inside. So you can now look back for those who are looking away. This is the resulting specimen that then comes out. You'll notice a couple things. We have from the proximal IJVs down through the azygos. The injection is actually from up on either side, both sides of the IJV and allowed to flow out the azygos. It's done at a pressure such that it's not expected to dilate the veins. And it's able to capture the hot areas that are thought to, that have been described with CCSVI. You'll notice that the more northerly portions of the IJV are not captured through this harvesting. It technically is very difficult to get much further north than what we had without disrupting the face, the mandible, and things like that. And we did not have that opportunity since some of these donors did expect an open casket funeral, so we had to be somewhat careful with defacing the face. Once we had the specimen out, it was then filleted open and pinned down to a corkboard board, like as shown here. It was photographed at both low power and then up at high power with a dissecting microscope, and all the valves and any other noted structures were then evaluated and analyzed with particular focus to these hot areas. What's circled here is these areas that have been reported to show abnormalities with the catheter-based venography. We also measured the wall circumference at different pre-specified areas, trying to capture and measure whether there was indeed stenosis in the specimens. We then took histology sections of the hotspots and all the valves and all the abnormalities and the structures that looked abnormal. The histology is still in process, so I will not be presenting that here. First, a couple comments about the anatomic variations. We found a variety of jugular valves, the most common being the bicuspid valve shown here. We also saw a tricuspid valves shown here, the probe through the 3 different cuspids. We also found a tricuspid valve where it was a relatively normal leaflet and 2 tiny leaflets. So tricuspid, sometimes equal tricuspid and sometimes variable in size. And there was the occasional unicuspid IJV as well. In terms of the overall prevalence, and this is from the entire sample of 10 MS and 10 non-MS patients, there was an IJV bilaterally in 85% of patients, but 15% of patients had an IJV in only one side or the other side, 10% in the left and 5% in the right. Completely absent bilaterally IJVs was not seen in any of our 20 specimens. The valve types, the majority were bicuspid valves, although there was about 16% tricuspid, and that's a variety of equally tricuspid and some with mini valves versus a normal-looking valve, and 5% with unicuspid valves. That's of the 37 valves that were seen in our 20 patients. Azygous valves or azygous valves were seen in 65% of the specimens that were collected. The average distance from the SVC when they were seen was 3.6 centimeters. Just as a comparison to what was seen in the literature, the diameter of our patients, and this is the IJV valve, about 7 millimeters on the right and a little bit less, 5.7 on the left. This is similar to what was seen by Dreser in another autopsy series. You'll notice that this is smaller than what is seen radiographically in live patients, and probably relates to, in the live patients, since that's a pressurized system, there's probably some dilation just from the normal physiologic pressure of blood flow through the system. So let me turn to the results looking at the pathologic changes. This is a description of the 6 and 7 subjects with MS and non-MS, relatively similar in age and breakdown of sex. We did see some normal valves, and I'm just showing you this again, a normal IJV. And we think that relates to what's seen here under the ultrasound with 2 leaflets of the IJV shown here, and with the direction of blood expected to be that direction. The azygous we also see here, and 3 leaflet IJV valves in the MS patients. Occasionally we also see a double set of valves, an IJV up here and also down here. So they look to be normal in appearance and function, and although we did not do any formal functional assessments of the valves, we didn't do any formal flow studies of any of the tissues that we collected. We did occasionally see hypoplasia or an annulus, and that's shown here, a narrowing of the vein wall. And this is, again, showing valves in the azygous. I'll note that this is always a reference image. This isn't always the updated example on each side, but just showing you where these specimens are collected. We also saw a flap that seemed to be an abnormally formed valve. Whether it developed or was congenital is unclear. And then this is showing the flap. It seems to be a free flapping flap, not anything that's anchored down beyond just that bottom edge. We think that may be related to what's seen under ultrasound of this enlarged leaflet that seems to be going across the entire vein as a single leaflet, although this is not from the same patient. This is from a live patient. We also saw occasional intraluminal membranes, and that's shown here. This is a look down into the IJV, into the internal jugular vein, and there is this membranous formed structure that's seen covering about 2/3 of the vein, or going across about 2/3 of the vein. This is it from another view. We think this may relate to this finding in ultrasound from one of our study patients, where this is the outline of the actual valve, and this is the actual flow going through the valve. And one can see that the majority of, not the valve, I'm sorry, the vein, the majority of the vein does not have color flow going through it, but only the very center portion, and we think that may relate to this sort of phenomena of a membrane that covers a large portion of the jugular vein. We saw other membranes as well. This is a longitudinally oriented rather than cross-sectionally oriented membrane, which is a very thin tissue not much meat within the tissue, as you can visualize the probe going behind it, and this is longitudinally along the vein. And this is a similar sort of structure, but there's more tissue. There's more meat, if you will, within that. Not quite a membrane. We're calling that a septum, although formal histology will further characterize what tissue is contained within that structure. We think that may relate or be representing what is seen here in some sort of structure that is going across the vein. This is cross-sectional of the internal jugular vein, transverse, where there's flow going through both sides, but this structure is here going down the center of the vein. So we're calling that a septum. There's also a sheath. So just a different way, and actually whether a septum is different from a sheath, we really don't know at this point, and when we do more histological studies, we'll have better clarity regarding that. So when we sum this all together, what do we find? Well, first looking at the narrowing. We define narrowing as 70% decrease in cross-sectional area relative to a more distal location. And what we found is 2 MS patients had that and 1 non-MS control had that. However, when we looked at the intravascular abnormalities, the things that were within the vein, we found that there was what appeared to be a higher incidence of them in the MS patients compared to the non-MS controls. And so putting both groups together, we saw 2 abnormalities among 2 of 6 non-MS controls, where we saw 9 abnormalities within 6 of 7 MS tissue donors. So that's what we saw in terms of structural abnormalities. We saw no differences in the variations, the things that we don't think have significant hemodynamic or would not be expected to have significant hemodynamic impact. These include 3 leaflet valves, duplicate IJV valves, absence or presence of azygous valves, small non-obstructive septums. These were found in similar frequencies in both the MS and the control subjects. The vein wall measurements, as I mentioned previously, they were a similar incidence at the 70% cutoff. When we changed that to a 50% reduction in area, we had a slight increase in the prevalence, but a similar distribution between the MS and the non-MS patients. 4 of the 7 MS donors had a 50% or larger stenosis or decrease in area. And 3 out of the 6 non-MS controls had a greater than 50% reduction in cross-sectional area. So in conclusion, structural vein abnormalities were observed in both MS and controls, non-MS controls. It seemed to be more common in the MS patients than the controls. We did not see frank stenoses, overall narrowing of the vein, like is shown on the left side. Instead, what we saw were entities within the vein, where the vein wall remained at a normal caliber, but the flow through the vein may be reduced due to structures contained within the veins. So these intraluminal structures, this then highlights the importance of ultrasound assessments that look specifically for these intraluminal structures, and that would be an important part of evaluating patients regarding CCSVI. And we think that this pathologically is what's being represented here and needs to be looked at specifically. A couple important caveats to our observations. This is a small sample size. This takes a lot of work to put together and to enroll patients into this and to perform these studies. These were not done blinded, although the histology will be done blinded. So the collection was done knowing who had MS and who didn't have MS. There is some possible confounding of the premortem medical management. MS patients are expected to have a more complex medical complications prior to death than the non-MS controls, and that may have had an impact, and we have some limitations in looking at the pre-death medical complication rate in our subjects. We are going to look at all 10 of the MS and non-MS control samples that we have collected and also do histologic analysis. Finally, do appreciate and acknowledge the generosity of our tissue donors making the ultimate contribution to MS research. So I'll stop there.
Thank you, Dr. Fox. It's good to see what really lesions look like, having seen them on ultrasound. We're well over time, and we will take one question.
Thank you, Dr. Fox. Bill Code, University of British Columbia. Priorities. Anyway, you mentioned they're reduced in size of either 70% or 50%. And I expect the 50% reduction probably comes from the arterial literature, right? Because that's seen as a significant restriction in size. In my background as anesthesiologist with so-called Poiseuille's law, whereas fourth power of the radius makes a difference in flow, in a low flow system, which of course what veins are, I'm hoping that you're also continuing to look at the smaller sizes of reduction, perhaps even a 30% reduction.
Well, we have the measurements. The measurements are there and are collected, and we can evaluate any cutoff one wants.
Okay.
My sense is that it's unlikely that we will see much of a difference, at least using the measurement methodology that we have. It's 50-50 at the 50% cutoff. If we go to 30%, probably it'll be much higher. There is a natural narrowing down around the valves. And I have a feeling the vast majority of both MS and non-MS controls will meet that criteria using the 30% cutoff.
Okay, thank you.
Thank you, Dr. Fox. The next presentation, multiple sclerosis and cerebral endothelial dysfunction, will be given by Dr. Alexander.
Is it okay? I'm good. They already plugged me in. Okay, it's starting up. I'd like to thank the organizers for allowing me to come here today and present some of my data. I'm an endothelial biologist, and I think my background makes it very interesting for me. I hope you would share some of my perspectives that we think that multiple sclerosis actually does represent, at least in part, a cerebrovascular dysfunction that arises in endothelial cells. And I'd like to thank some of my collaborators here, Dr. Vijay Ganta and Ali Minagar, who's a neurologist at LSU. And just a couple of disclosures. I'm currently funded by the Department of Defense to study plasma endothelial microparticles, and I have a drug study going on with Afios Corporation on Alzheimer's disease, Northwest Louisiana brain and spinal cord injury, and we have a grant on stroke injury from the Feist Cardiovascular Foundation. So, cerebrovascular endothelial stress clearly appears to contribute to the etiology of several neurovascular diseases, not only multiple sclerosis, but there seems to be a cerebral microangiopathy associated with Alzheimer's and, of course, stroke injury, as we heard. What I'm going to show you a little bit today is that hypoxic and aglycemic stresses actually depress endothelial metabolism, and this hypoxic and aglycemic stress on the endothelium increases the presentation and the expression of endothelial adhesion molecules, ECAMs. And what we find is that when this occurs, cytokines that are present during the cytokine storm associated with MS, those synergize with these hypoxic and aglycemic stresses and greatly intensify the expression of ECAMs. And that could be very important in converting the binding of leukocytes into frank inflammation. And one of the things I'm going to end on is endothelial microparticles. Endothelial microparticles are a new structure that's found in plasma and serum, and these are derived in many cases from endothelial cells, and they represent very good evidence that this is in fact a cerebrovascular endothelial dysfunction. And these are released in response to inflammatory and hydrodynamic changes in the endothelial cell's microenvironment. So we're going to look at how brain endothelial hypoxia and metabolic stress interacts with other blood-brain barrier components and inflammatory cytokines to modulate ECAMs. We're going to look at how EMPs are altered by inflammatory challenges and shear, and maybe touch on examining how these generated EMPs may contribute to vascular stresses in human MS. So if you're talking about The cerebral endothelial dysfunction, what I'm showing here is supposed to be an endothelial monolayer, and normally when it's happy in response to shear, it's producing nitric oxide. And this is sort of getting back to Dr. Guy's talk this morning. But under appropriate stimulation, if shear is abnormal or if there's an abundance of Th type 1 cytokines, ECAMs, such as selectins and IgCAMs, are mobilized to the surface of the endothelial cell, making it very sticky. And when that occurs, this allows for junctional reorganization under these conditions. We also have evolution of microparticles, as I'll show you, and all of these together will lead to the movement of leukocytes from the bloodstream into the parenchyma that contribute to the development of perivenular cuffs, injury, and cell stress. And ultimately, of course, this can trigger endothelial apoptosis. So there's pretty good evidence that intermittent hypoxic and ischemic stresses contribute to the etiology of MS. I had been planning to talk about Lossman's work on type 3 lesions in response to hypoxic-like injury. And then this morning we saw that Dr. Guy, Ivatanov, and Hubbard presented a lot of evidence suggesting that compromised blood flow in MS may be a significant feature of the disease. Some of the models that we're using, we have in vivo and in vitro models. We have a hypoxic, hypoglycemic model of human brain endothelial cells and neuroblastoma and astrocytes. As well, we have a fluid shear modeling model that we developed, and we also have in vivo models with mice. Okay. So one of the things we noticed when we started doing these experiments, we were looking at how the metabolism of endothelial cells was affected by hypoxia or glucose deprivation. And what we found was, what you see on the vertical axis, this is the cell metabolism. And under normal circumstances, their metabolism is shown on the left. Aglycemia, endothelial cells are really sensitive to changes in the glucose in their environment. That really depresses them. And if you take away oxygen, endothelial cells are designed to withstand hypoxic stresses, and they do that pretty well. And the combined oxygen and aglycemic stress really depresses them significantly. Now, if you were to add on top of that, what do these challenges do, for example, to some of the ECAMs that we think drive this disease? Well, if you look at these stresses, all by themselves, without any additional cytokines, you can see that VCAM, E-selectin, MADCAM, and P-selectin, these are all actually increased without any other additional stress, simply by metabolic challenge. Okay? That says without any additional inflammatory response, you're triggering this. And if you look at the effect of inflammatory cytokines as well, if you look, this is a mouse brain, 2 human brain endothelial cell lines, and a control cell line. All of these are depressed by inflammatory cytokines, TNF, IL-1, interferon. So you can imagine that in combination, this produces a significant and severe stress on the endothelial cell. And what I was going to show you here, this is an example of some of our cell Eliza studies where we're looking at the fold change in the expression of, in this case, ICAM and TNF alpha. And what I'll show you here is that oxygen and glucose deprivation combined with TNF gives you, if you look, this is actually a significant increase over the normal response you'd have with TNF alone. And I could show you a lot of these different graphs, and there are several that I could go through, but I'm simply going to say we're going to look at the P-selectin, E-selectin, ICAM, VCAM, PCAM, and MADCAM in response to TNF, IL-1, and interferon, the cytokine storm, and then in response to hypoxia, aglycemia, and OGD. And I'll make this fairly simple for you. If you simply look at the number of red up arrows, this tells you the circumstances under which we saw a significant intensification of the expression of these adhesion molecules. There's a couple where it went down, but together, these really intensify the response. And I'll just point out that this bar here, this is VCAM. VCAM is actually one of the targets for natalizumab, which is currently an important treatment for MS. So these manipulations actually lead to the evolution of adhesion molecules that can drive the disease process that we associate with MS in the endothelium. So hypoxic and aglycemic stresses provoke alterations in ECAMs where they are upregulated. They synergize with cytokine inductions. And together, this may lead to hyperintense leukocyte and platelet binding that leads to neurovascular stress under these circumstances. Now, I'd shown you here that inflammatory cytokines suppress brain endothelial cell metabolism in several different models. And then if you look at multicellular models, this is with, these are cytokines plus endothelial cells and fetal astrocytes or astrocyte conditioned media. TNF in particular, in combination with these stresses, produces a tremendous metabolic suppression. And we're really curious whether or not multicellular models will lead to a better understanding of what's going on under these circumstances. Now, if you look at the barrier function that's going on, the barrier function changes that we see in response to cytokine exposure, what you see on the left here, you will see some changes with inflammatory cytokines when there are no astrocytes present. But if you look at the graph on the right, shown here, when you add astrocytes, it appears that the astrocytes intensify and magnify the barrier responses. So it may be that the cytokine storm and the metabolic challenge is affecting both the endothelial cell and other cells in the blood-brain barrier to lead to changes in barrier. And when this barrier is changed, that's when we can see some of the phenomenon that we associate with these neuroradiologic findings in MS. Now, things that are present in MS serum, we suppose that there are cytokines, but in this study, what I'm showing here is on the top left, this simply shows the apoptosis of endothelial cells that have been exposed to multiple sclerosis serum. And the top right shows that this is only present, these factors are only present during relapse. This is the number of apoptotic cells that we would see, and it's significantly increased in relapse, but during remission, these factors that would be producing apoptosis are no longer present. On the lower left, you can see that interferon beta is one of the more common treatments for this. This actually relieves and reverses partly some of the stress that we see, but it's a dose-dependent effect, and it's interesting that only modest levels of interferon beta are protective, and we lose that effect when we go too high. And interestingly, we think that, and this gets to what Dr. Gee was talking about this morning, we think that part of this may reflect the induction of nitric oxide when these cultures are actually exposed to modest amounts of interferon beta, but not higher. Okay, so there may be some benefit here, but this is really an endothelial apoptosis. The vascular lining is becoming stressed to the point that it's undergoing programmed death responses. Next, I'm going to talk to you about another piece of evidence for endothelial stress. These are endothelial microparticles, and these are released from the lining of the vasculature. And these are membrane fragments that are derived from cells. They are always present. I'm not going to say that they're not present in normal controls. They're always there. They're less than a micron, and they bear a lot of endothelial cell surface markers. Whether or not and what they contribute is currently unclear, and it's a fascinating opportunity for us. Interestingly, caspase-3 is concentrated in microparticles, and if cells are prevented from shedding these microparticles, they die. So it may be a way of the cell purging itself of toxic parts of its membrane under those circumstances. They clearly appear to trigger secondary immune responses after viral and inflammatory and hypoxic responses. And what you're seeing here on the left, these are phase contrast brain endothelial cells that have been incubated with microparticles that have their cytoplasm labeled with fluorescein diacetate. And if you look on the right, you can see these discrete circles that are actually fluorescein diacetate, and they're binding, interestingly, around the nucleus of these brain endothelial cells. Okay? And if I take a culture of human brain endothelial cells, and I expose them either to TNF or interferon, I'm getting a very large and significant increase in the numbers of these microparticles that are shed from the endothelial cells. They don't die under these circumstances, but they're releasing many, many more of these microparticles. Now, to look at a microparticle, we said it's less than a micron. Typically, it's about 100 nanometers. That's how we define them. If they're approximately 100 100 nanometer, and all microparticles express annexin 5, which is a proapoptotic marker that binds to phosphatidylserine. So phosphatidylserine can be marked by annexin in our flow cytometry studies. ECAMs are present. We see that here ICAM, or CD54, is present on the surface of these microparticles. So is PCAM. MADCAM is expressed under appropriate stimulation. So is VCAM. And junctional molecules, interestingly, these are present on the cells, but these are not present in most of the microparticles. Pancadherin is absent, as you can see. Occludin, a component of the tight junction, is absent, so they're shedding apical bits of the membrane, right? These are not being shed from the junction. Interestingly, they do express ephrins, which are important vascular regulators. And one of the more interesting things that our lab has found is that these microparticles contain amyloid precursor protein. And this was a striking finding for us when we actually found this. And I'll talk a little bit about that. Okay, if you look in normal individuals at CD31 PCAM, CD146, CD54 containing microparticles, at the beginning of these patients' therapy, they had high levels of microparticles, and when they were treated persistently over the course of 12 months with interferon beta, the levels of these particles went down for CD31 and CD54. And when we tracked that with post-contrast T1 weighted imaging, we could see that the two of those seemed to be related. So the degree of radiologic improvement was actually correlated with at least two of these markers that we were interested in. So we feel that these markers have been validated to some degree as far as their relationship is going to radiologic evidence for T1 weighted lesions. And we're following this up now. Another marker that's very, very important is the Efference and F receptors. These are vascular regulators, and what you can see is that the Efferent A1 on the top right, these microparticles express Efferent A1, and this is really an interesting finding because Efferent A1 is a ligand that can trigger downstream inflammation when it binds to FA2 on other endothelial cells at a point distant from the point that it was actually generated, which is a striking finding. FA2 and FA4 are also present, but only FA2 is modulated. When we looked at these in samples of actual MS tissue, we find that Efferent A1 is increased, and Efferent A4 was also increased in the human brain where FA2 is not, and we're currently trying to figure out exactly what the significance of this might be. Now, coming back to the findings on the APP-positive microparticles, what we did an experiment here, what you see on the left and what you have on the right. We cultured human brain endothelial cells on porous filters that allowed anything that was 1 micron or smaller to pass through, like a microparticle. And then we treated them with TNF and interferon, the cytokines, storm-associated cytokines. And what we found was that normally, of course, endothelial cells are forming these particles and they're releasing them apically. But what we see is that endothelial cells where we actually study what goes underneath the cell, or what in vivo would be outside in the perivasculature, is that you lose this from you lose these microparticles into the bloodstream, but actually, if you look at the ratio of the apical to basolateral, you're shedding more of these microparticles into the parenchyma after you are stimulating them with inflammatory cytokines, which was a really striking finding. It means that for the first time we have a means of transferring an endothelial pro-inflammatory molecule that could be converted into something very toxic, specifically beta amyloid, in the vasculature. And once this gets there, once this AP precursor gets to the vasculature, what happens to it? Well, you can see that this protein is found extravascularly, even in controls. We did 6E10 staining, and that's the red that you see. Negative control in the middle, we see no staining. But it's really very striking that Perivascularly, we see this staining is very prominent around blood vessels, and these appear to be veins in our hands. Now, if that precursor should come into contact with the angiotensin, beta amyloid converting enzyme, it will actually convert it into beta amyloid, and that can have very serious consequences at the vascular level. One of the things we're currently studying now is a drug that's called bryostatin. This is currently in development for an Alzheimer's treatment. We find that it causes bryostatin causes the release of BACE1 from the endothelial, from the neuron rather, such that these two ships in the night should not actually meet, and that will lower the actual conversion and formation of beta amyloid in these models. Just to put some stuff out there about jugular inflammation that we think is going on. These are studies done with Matteo Cohen and Marie Beaucheton-Pialat. We think that there may be a disturbance in the vena venorum. These are jugular veins taken from control on MS. There seems to be a relative rarefaction of lymphatics, and that'll be borne out by additional stains and analysis, as well as the amount of blood vessels in these seem to be diminished, and that's a striking finding, and that could lead to additional stress in these tissues. Not to saying that, as Dr. Fox showed, this may really originate in the valves, but that may lead to changes in the structure of these vessels. Lastly, I'm going to show you two slides. These are correlations between MRI and MS serum microparticles. This is some of the work we're doing for the DoD. We found that in relapsing remitting MS, there are, in fact, these are findings with conventional MRI. We do find that microparticles are associated with specific things, specifically T1 hypointense lesions, for example, CNX 2.5 in painting in white matter. But interestingly, and Robert Zivadinov let me present this, is that the correlation between iron deposition and MS serum appears to be pretty important in these, such that when you look at RRMS and secondary progressive MS, we do find that certain structures in the brain can be correlated with the elevated production of, or elevated deposition of iron, and that tracks with specific microparticle fractions that we're interested in. Very lastly, to put this all in perspective with flow and shear, one of our new models is the shear ring. We culture our endothelial cells in these from the brain, and then these things are rotated, and under rotation they experience fluid shear. And an interesting thing that we're finding now is that when these cells are exposed to fluid shear, what you see here with the arrows coming down is the microparticles that are released are in fact, they are releasing more APP, and that is a flow-dependent phenomenon. I don't think that's been shown before. So turbulent flow provokes the release of endothelial microparticles, and studies indicate that I'm not showing you indicate that energy metabolism is altered, and probably apoptosis is going to be affected. We're doing barrier studies at the moment. I wanted to present that to you, but we didn't have it finished at the time. And just pointing out, microparticles may remove markers from the endothelial cell that are beneficial, and they actually appear to represent a significant fraction of the pool of the so-called circulating ECAMs, SICAM, et cetera, SVCAM. So in summary, metabolic stress activates a lot of endothelial programs that are associated with inflammation that are also present during MS, and I think this goes to point the way towards cerebral vascular endothelial stress as an MS mechanism. Microparticles are shed during this type of stress and represent an important marker of disease, and now we can correlate them with brain iron deposition, and we're trying to take this story further, and I hope to report to you on our future findings. I'd like to thank a lot of people working with me. I won't read the list, but everyone here has contributed significantly to the work, and I thank you for your attention.
Thank you, Dr. Alexander, for a wonderful presentation. You've given us so much food for thought. Some of us are beginning to think that we know what to measure before and after angioplasty in our MS patients, and thank you very much. We're way over time, so we won't have any questions on this one. But any of you, and I'm sure, I wish we had half an hour to discuss all this, but could you please ask Dr. Alexander during the coffee break any questions you have? We now go on. We now go on to the SVC syndrome. Does it teach us about CCSVI? And this will be presented by Dr. Haskell.
Thank you. My tremendous congratulations to the leadership of the ISNVD and also for the extraordinary participants representing so many disciplines here. This has been the beginning of very many societies and very many endeavors. We think back of the Society of Interventional Radiology more than 25 years ago, and it was about 12 people. There are still these pictures. Talking about a field that was very controversial, even peripheral angioplasty. And many things that have arisen from interventional radiology are de facto first-line treatments now and face some of the same controversy but have to be driven by the same evidence. And it may well be that this is the same process that hopefully we're going to see assembled here. So we go from real science to something that is a bit more macro and more descriptive and perhaps analogous, but certainly not on the level of what we've just heard in endothelial biology. And the question is, does SVC syndrome, as another manifestation of venous obstruction, have some reference or some connection to that which we're talking about? So first, what is it? We have a mixture of practitioners and basic scientists from different specialties and advocates as well. So some of this will be basic to some of you, not to other ones. It's obstruction of venous outflow from the head, from the chest, from the upper extremities. The classic sorts of findings and the most extreme, exaggerated, are the swollen face, swollen neck, and such. It's kind of ironic that, in fact, that Marty Feldman is provided as an advertisement for this health system. I'm not sure that that would actually draw me to Oswego Health. But that aside, this is just an example of a patient that I'll show you otherwise with venous and central obstructions that presented with SVC syndrome. So first, what are the symptoms? They can begin suddenly. They can be a very gradual onset. They're worse when people bend over or lie down, increased pressure. The early signs, swelling around the eyes, the face, the sclera, maybe worse in the morning when you've been supine before being vertical. And then as they progress, shortness of breath, dyspnea, impairment of respiration, swelling of the arms, chest, and the neck. Here are some other interesting symptoms: decreased alertness, dizziness, syncope, headaches, reddish face and cheeks, reddish palms, mucous membranes as well, color changes, fullness in the ears, and some visual changes as well. Maybe you can see some analogies as well with other venous obstructions. Perhaps some of these sound familiar. Just one patient that I took care of who had bilateral high venous obstructions, whose primary symptom was a burning tongue, a tight band around her head, a headache, absolutely no facial swelling whatsoever. And they sounded and felt like very early types of SVC syndrome kinds of symptoms as well, and those had abated after treatment. There is a scale for grading SVC syndrome as well, and they include these following types of symptoms from laryngeal, thoracic, nasal, facial, etc., but they also include these neurologic symptoms that I mentioned to you as well. And we use these scales when we report papers to try to allow comparison to other series as well. Changes in maintain, alertness, anxiety. Here's one example: 42-year-old woman with SVC syndrome. She had been treated for Hodgkin's disease with radiation. She had facial swelling that would progress with exertion, none at rest, but she had increasing episodes of syncope. And just some pictures for the interventionalist. This is an injection of her port. And actually the end of the port fills the azygos vein. So the azygos vein is actually flowing retrograde. And then study of her arm shows no flow in the superior vena cava. That's after treatment. The literature for SVC syndrome is long-standing and extensive. One of our speakers wrote one of the earliest papers in 1994 describing the use of stents. There are many papers, they continue to be published, but they don't necessarily look at the types of symptoms that we're talking about, because most of the gross symptoms that we treat are really very dramatic arm and facial swelling, these sort of, dare I say, milder neurologic ones in comparison aren't really broken out. Some of the interesting things, though, for those of us who treat them is the average time to treatment. Here's a narrowing, there's a stent placement, is actually 40 days. So even with these prominent findings, patients can go for quite some time before meeting an interventionalist who may be able to improve this flow. Now, just to give you some practical examples as well, this is a patient with a full-blown SVC syndrome, swelling these collateral veins. This is a vein in the arm, a narrowing, and then an obstruction of the brachiocephalic vein, collateral veins, that may be a thoracic or internal mammary. Blockage from the other side, you can see how narrow it is, and that's amidst reopening it. There's another subset of patients that's very affected by stenoses and actually iatrogenic, physician-caused, dialysis patients. We place catheters for hemodialysis. Several 100,000 patients a year are dialyzed in the U.S. Many of them at some point have had catheters on the way to permanent access or during a period of failure of a permanent access. And these catheters, depending on where they contact in these veins, will cause narrowings. For example, the left side will come down, make a turn over here, contact over here, and create a classic narrowing here and also here. Anywhere there's wall contact, there's an intimal injury and eventually clot and subsequent stenosis. So we might think that we might know something about these types of neurologic symptoms in a dialysis patient. I'll come back to that. The other major population are cancer patients, either by direct involvement, by compression, or in even rare cases, even intra-vein. When we deal these things, we have really just brute force types of approaches, which is to use stents to open these types of veins. And what's interesting is that we rarely open the internal jugular veins. We virtually always just open the superior vena cava if it's obstructed, and then the veins in from the arms. And that's the patient that I showed you before, and stents that actually reach into the SVC in a parallel side-by-side fashion. That's the patient a short time later. There are some mechanical issues that have to be dealt with that continue to occur in order to be able to provide more durable treatments, and there are some device inadequacies. This is just from a very large series that shows an initial lesion, a treatment. I think I would look at this and say that this is inadequately treatment and an incipient later lesion, and indeed there is restenosis, intrastent restenosis, something that we've heard about for other veins during this conference that required reintervention. Can you fix just one side? And what I'm sort of talking about is, can we reduce symptoms by fixing only a fraction of the side or just one side? And as we've been thinking about whether and how these relate to other neurovascular diseases, we talk about the need for sort of complete revascularization and identifying lesions. And yet with SVC syndrome, we can often fix one side if necessary. Still, it's a poor fallback. This is the extreme sort of full-blown SVC syndrome, someone who's actually on a ventilator as a result of this. Obstruction of the jugular vein as well as all of the central veins, a prior stent placed in this dialysis patient, which is not only fractured but blocked as well. And interventions in reopening this and having to drill through stents. And short story is I could not reopen his jugular vein. I did stent everything else, and that's the patient 2 weeks later. I can't say that I gave him a neurologic exam. There certainly wasn't one beforehand in terms of what his mental function was, and I met him when he was on a ventilator. Certainly this didn't appear overnight. But I don't think that in any of the literature, and certainly from personal experience, that we have drilled down to that type of thing. This actually even affects children. This is an example of a child that I treated at 7 months old, in which there was only one possible revascularization, which was the left side. So we've only fixed one single vein after working on everything else. This was actually a iatrogenic cause. And in that case, in that child, this is now 4 years follow-up, and that child is making her cognitive milestones very well, although I will tell you that her head is well beyond normal circumference. So whether this will turn into something or not, whether there's signal here, don't know. We do have issues with devices that have to be addressed with restenosis, same issues that plague stents that we place in other venous territories and certainly in jugular and other areas. And I expect that for SVC we'll see devices that actually have graft material, Teflon-type polytetrafluoroethylene, and otherwise to be able to reduce this recurring problem. We are far from having ideal technology for stenting in central veins, even though we have been using stents in this area since 1992. Here's just an example as I want to try to make an argument by analogy. This is a patient who has a narrowing on one side. The other side is presumably blocked. Someone addressed one single side, and this is how he was for some weeks thereafter. I met him and I reopened his other side. And that's what he looks like now. So the point is that this is somebody with low-grade chronic SVC syndrome that was under-recognized from having just one side repaired. We don't know how much we have to treat. There's a higher prevalence of under-diagnosed and under-recognized SVC syndrome in patients. This is a 25-year-old, 26-year-old with a dialysis graft who for many, many months was essentially treated periodically and sort of managed as an obese African-American woman. And I met her and did some other interventions with stent grafts and otherwise. This is what she looks like in follow-up just a couple weeks later. She hasn't looked this thin, if you will, for 13 months. That's chronic low-grade SVC syndrome. Again, I don't know whether she had any of the relevant neurologic findings because it never occurred to me to ask these things. But you can go into a dialysis ward and find many, many patients just like this who are managed and tolerated with low-grade SVC syndrome. And I'd suggest to you that that's an open research opportunity that should be looked at. Given the number of people that get dialyzed and the over $12 billion that we spend on end-stage renal disease in the U.S., there's a captive population that could be looked at that has venous hypertension by virtue of an access graft and has central vein stenosis by virtue of catheters that may well have an exaggeration of a neurovascular venous disease, and maybe some of these referenced venous findings that might prompt earlier intervention might fold into what we're talking about at this meeting. About dialysis patients right now, it's a very noisy subject because there are so many other things that determine quality of life, electrolyte abnormalities, being a sick patient who has to be on dialysis for many hours several times a week, quality of life issues in general that make it hard to sort of separate this thing out. Maybe there's a time in saddle for these symptoms as well. Even here at this conference in the hallway, though, we have at least one example on a poster. Another colleague who's talked to me about a patient who has developed some of these symptoms that have reversed, non-MS, with opening veins. I think it's an open question to determine whether this is signal or noise. For the interventionalist, just a cautionary note as I start to wrap up, particularly in dialysis patients where we place a lot of these things because of subsequent catheter placements. These are some examples loaned to me by a colleague of a stent that was placed here who was then sent for a catheter. The physician who tried to place the catheter without fluoroscopy didn't realize there was stent here and managed to create a near lethal injury into the chest in that situation. This is a different patient that was loaned to me who had a narrowing stretched in the superior vena cava, who had immediate respiratory arrest. That was actually a rupture that was shown on autopsy as well. We do these types of procedures many, many times, and yet for the practicing physician, it's always important to be vigilant and understand that this can, in rare cases, be a very high-risk area, and success comes to the prepared mind. So, as I close with the next 3 slides, there are several messages here. It's undertreated, it's delayed, it's under-recognized. It can be treated rapidly by transcatheter techniques, almost regardless of extent, even with extensive clot. The neurovascular component, I'd suggest, is still weakly understood, but it seems as if there's a crossover, and there ought to be some linkage just from the symptoms and just from these examples. We should be intervening earlier in these patients. We should be using revascularization More often, it's underutilized. We should be sensitive to lower levels of SVC syndrome for all these types of things, venous hypertension in extremity, in the neck and the face. We'll be looking for more devices in the near future. And there really is, I think, a curious crossover in symptoms for acute and milder SVC syndrome, where we actually have the opportunity to ask these questions of patients. They may well have resonance with the CCSVI symptomatology that we've talked about here and in other neurovascular diseases. This is a small and more heterogeneous subset with more advanced disease, but in fact there is perhaps a much larger undertreated population, particularly in end-stage renal disease, and it's a good opportunity for asking more questions. Thank you very much.
Thank you, Dr. Haskell, for giving us more food for thought. We're now going to the last presentation, which I will make. Great, thank you. What I'm going to present to you is has nothing to do with the CCSVI, but is a follow-up on what was presented in Bologna by Dr. Piazzi. And this will bring the audience, especially the neurologists and ultrasonographers, up to date with the very hot topic currently being discussed on the subject. The basis of the current practice for asymptomatic carotid stenosis are the two randomized control studies, the ACAS and the CST, which showed that for asymptomatic patients with more than 70% stenosis, the perioperative stroke death is 2.3%, but carotid endarterectomy will reduce stroke from 2% to 1%. And of course, all the implications are there that you have to operate on 90 patients to prevent one stroke in 1 year. More recently, Ross Naylor and Ann Abbott showed that the annual ipsilateral and any stroke by year of publication in natural history studies has been decreasing. And between the year 2004 and 2009, it's down to 1% per year. And there is a strong body of people who say you shouldn't do a carotid endarterectomy on anybody these days because, look, this is the effect of statins. So we say that if patient subgroups with sufficiently higher than average risk, despite optimal therapy, could still be identified, then surgery may be justified. And I'm going to tell you how this is done. About 10 years ago, we set up the ACSRS study, and some people in this room have taken place, have contributed to it. And the aim was to determine the risk stratification for stroke using the degree of stenosis, clinical features, and plaque characteristics. In this study, we had patients with asymptomatic carotid stenosis more than 50%, and we excluded those who had contralateral symptoms within the last 6 months. We had criteria about the center eligibility. They should have a non-invasive vascular lab. They should have experienced investigators. They should have a neurologist, vascular physician, and so on. And this was a truly multi-center European study with the addition of a center from Australia. And we collected clinical, biochemical, and and about 821 had a CT brain scan, and we looked for cardioembolic infarcts. Everybody had a duplex examination to grade the degree of stenosis. Everything was recorded on video, and all the ultrasonographers came to the coordinated center for training, and I'll tell you a little bit about this training in a minute. Every patient was followed every 6 months, not so much for the duplex, but so much for the neurologists to examine them. At the beginning of the study, there were criteria established so that everybody had them to grade the degree of stenosis, and the stenosis was graded based on these criteria, both using the NASCET method and the ECST method. And here is what we did, why we did the training. And this is related to the arguments we have today on the CCSVI. First of all, ultrasonographers had to be taught on the equipment settings for the image analysis. Also, how to obtain the images properly. And to give you an example, everybody talks about Doppler velocities at 60 degrees, but if you're doing image analysis of plaques, the ultrasonic beam has to be at right angles to the arterial wall. And here is a list of other things that we train them for. For a trained, accredited ultrasonographer, this can be learned in a day. And with that training, they were able to obtain images like that. And here you see the common carotid. Here you see the external. Here you see the internal. This is the bulb, and you can see a very large plaque here with a very large lipid core in the middle. And this is when you turn the color flow on. All the images were normalized using commercially available software, so that black had a gray scale of 0, and adventitia had a gray scale of 190. And you must all know that on your PC, the gray scale goes from 0 to 255. The plaques were then sectioned using the mouse. They were saved as a separate file. And then they were contoured depending on the grayscale of the pixels into different shades. Much easier for the human eye. This is what other people call virtual histology. And then a number of features were extracted, and time doesn't allow me to go into that. Let's come to the endpoints. The follow-up was maximum 8 years in this study, with a mean of 4 years. And the primary endpoints were ipsilateral events and ipsilateral stroke. And we had a number of deaths, and of course most of them were cardiovascular. And we all know that patients who have asymptomatic carotid stenosis are arteriopaths, and most of them die from myocardial infarction. Here are the neurological events, and we had 130 ischemic neurological ipsilateral events and 59 strokes, and I want you to concentrate on that. And let's look at the results of the silent embolic infarcts. And I'm talking about small cortical, discrete subcortical beta ganglia, and all these CTs were evaluated by an experienced neuroradiologist, John Stevens from Queen Square. And the message that comes out of this is that if you have the people who have embolic infarcts are those who had a higher incidence of stroke, and this was on average 3.6 per year, in contrast to the rest of the patients that did not have such embolic signals. So here we have one feature that can predict a high-risk group. Factors associated with ipsilateral cerebral ischemic events are listed here. And then let's look at stenosis. If you look at stenosis, the people who had 90 to 99% stenosis are here. They're a high-risk group with an annual stroke rate of 2.4%. But in this group, we have only 25 of these strokes. The other strokes were in the people who had smaller degrees of stenosis. So stenosis is not the ideal method to do the job. What about plaques? Plaque type 1, very black plaque. Plaque type 2, those of you who are ultrasonographers know what I'm talking about. Plaque type 3 has more collagen, and plaque type 4 is very bright, very solid. It never gives you trouble. But look at the data. If you have plaque type 4 and 5, which means the very echogenic plaque I've just shown you, or calcified plaque, you can go on for 8 years and you hardly get a stroke. So you can forget these patients. You can say there's no need to do a carotid endarterectomy. They don't get into trouble. If I do carotid endarterectomy, I'm going to produce more strokes as part of the operation. And here, the high-risk group that were type 1, 2, and 3, we had the majority of the strokes. What about the grayscale median? The A low grayscale median indicates the plaque is very black, ecolucent, without collagen, full of cholesterol. Well, if you have a low grayscale median, 15, less than 15, you have a high-risk group that contains 32 of the 59 strokes and an annual stroke rate of 3%. So that's another way of identifying a high-risk group. And then, what about the plaque area? We were able to measure plaque area in square millimeters. And again, if you have a plaque that has an area greater than 80 millimeters square, you still have a high-risk group, but it doesn't contain most of the strokes because only 114 patients followed this rule. And finally, the plaque that has these discrete white areas is the most dangerous of all. And these white discrete areas are not calcifications, there are no acoustic shadows. They're vessels, very much like we do an ultrasound in the liver, and you have an angioma, and it shines. This is what this is. And it has been proven by microperfusion. And I have no time, and I'm going to skip the next few slides to demonstrate this. And I'd like to tell you that if you have this type of plaque, it makes no difference for the first 4 or 5 years, but after that, it does identify a high-risk group that does contain the majority of the strokes. So if there was one other feature, a history of contralateral TIAs or stroke. And if that was present, also we had a high-risk group. So if you take the clinical factors only, we find three features that are significant. If you combine these features with the plaque features, we end up with 5 features. Stenosis, grayscale median, is just normalized like this, the plaque area, the presence of discrete white areas, and the history of contralateral TIAs, stroke. And using this model, it's possible to calculate the risk for every single patient. And here, you can see the diagnostic value, and here is the ROC curve for stenosis alone. This is the ROC curve for stenosis and clinical symptoms. And here is the ROC curve for stenosis, clinical symptoms, and plaque texture features. And by calculating the risk for every patient, it was possible to use a table like this, depending on plaque area, grayscale median, presence of history of contralateral TIAs or stroke, so that for the 80 to 99% stenosis, the range went from 0.5% to 10% annual stroke rate. And from 50 to 79% stenosis, it went from 0.2% to 8.7%. In other words, 524 patients had less than 1% annual stroke rate, and with about 200 people, 200 patients, had an annual stroke rate that was high enough to merit a procedure. And this slide shows the grouped 5-year predicted risk of stroke based on the model against the actual observed 5-year stroke rate. So the model works very well. It's an internal calibration. So the conclusion is that risk stratification is possible. And on the basis of this model, the risk of stroke can be calculated for every patient. And the equation is published. And what's available now, there is commercially available software that will do the image analysis, and it will only add 10 minutes to your ultrasound examination. And it automatically produces a report like that. And it says that in this particular plaque, the annual risk of stroke is 4.5% per year. And our surgeons in London are very happy to see this sort of figure, and it helps them in their decision making. The second point is that we need to test the value of risk stratification factors in patients who are now on modern medical therapy. Because 10 years ago, we would treat them with statins and prescribe 10 milligrams, 20 milligrams. Now, we treat to target. We want the cholesterol to go down to 150, or the LDL to 90. And that is what we have to do now. In the meantime, we can tentatively suggest that patients with asymptomatic high-risk plaques having a stroke risk of more than 2% per year should be considered for surgery. And this is my message. And you're going to hear a lot of controversy over the next few years and lots of debates on this subject. And if you're aware of this, then you'll understand why some people say, I have to operate on everybody, and some people say I have to select them, and why some people say you shouldn't operate on anybody. You're going to hear all these arguments. Thank you very much. Right. I am told that we are going to go out for the posters and the coffee, and we will start at 3:15. Thank you very much. If you have any questions, you can meet me at coffee.